Thank you, Lynn, for the introduction. Ladies and gentlemen, dear colleagues, I'm honored to have the opportunity to discuss with you the issue of advanced practice nursing and adult congenital heart disease outcomes here at the World Congress of Cardiology in Dubai. I have no disclosures. Congenital heart disease is defined as gross structural abnormalities of the heart or intrathoracic grade vessels, which are actually or potentially of functional importance. And the generally accepted incidence of congenital heart disease is about 8 per 1,000 newborns. However, more recently, variations in the different continents have been found. 8% is indeed the figure that is found in North America or in Europe, but the incidence appears to be much higher in Asia, and therefore it is recently pointed out that the worldwide incidence of congenital heart disease is estimated to be about 9.1 in 1,000 newborns. Over the past decades, the survival of the patients has increased substantially. And you can see this in this figure. These are the survival rates in previous decades. However, children who were born in the early 90s, and it's indicated with the yellow line here, do have a chance of 90% to survive into adulthood, which really shows the dramatic improvements in medical care for these patients over the past decades. And of course, this also resulted in an increased prevalence of congenital heart disease in society. Based on literature that was published up to 10 years ago, it was estimated that there were about 2,600 to 5,000 persons with congenital heart disease per million inhabitants. Looking at the adults, it was estimated to be 1,700 to 3,700 per million inhabitants. But more recent data obtained in Quebec in Canada calculated that there were overall about 5,780 patients per million inhabitants, and for the adults it was about 4,000 adult patients per million adults. So roughly we can say that there are more than 3,000 adult patients per million inhabitants. And irrespective the initial treatment that patients received in the early ages of their life, they cannot be considered to be cured. These patients remain vulnerable for complications such as arrhythmias, heart failure, pulmonary arterial hypertension, and so on. But in addition to the medical problems, these patients also have some non-medical problems. And I would like to, just as an illustration, to show you some of these non-medical problems. And one of them is indeed the health-compromising behaviors. These are results of a study that we recently did in adolescents with congenital heart disease. And we found that about 50% of the patients used alcohol on a regular basis, and this is not problematic. However, 11% of the patients performed binge drinking, and this can be problematic because most of these patients are indeed vulnerable for developing arrhythmias. 7% smoked cigarettes on a regular basis, and this was a cohort from the age of 14 to 18 years. 3% used illicit drugs on an occasional basis. When we looked at the health behaviors in terms of dental hygiene, 11% had no dental visits during the past year. And we know for these patients it is important to have good dental hygiene in terms of prevention of endocarditis. 65% never flossed their teeth, which is a huge number. And you can imagine what happens if a patient doesn't brush their teeth. And indeed, about 80% of our patients admitted to not brush their teeth daily. In terms of physical activities, 22% did not perform any physical activities. Was this because they could not do it or they didn't want to do it? That's another issue, of course. But these patients do not only have behavioral challenges, also emotional challenges. Indeed, depression and anxiety is a prevalent problem. And Adrienne Kovacs from Toronto in Canada found in her study that 50% of the patients meet the diagnostic criteria for at least one lifetime mood and anxiety disorder. So also the psychiatric comorbidities are huge. And therefore, and again, these are just two examples, but these two examples clearly show that indeed there is a need for advanced practice nurses who are taking up the role of counseling, guiding patients for their non-medical problems. But to what extent advanced practice nurses are involved in the care for patients with congenital heart disease? Well, these are data from a survey conducted in Europe, and this survey investigated all adult congenital heart disease programs in Europe, and overall 70 of these programs were identified. And specialist centers, adult congenital heart disease specialist centers, were defined as those centers with pediatric cardiology or congenital cardiac surgery, at least one adult congenital heart disease cardiologist on staff, and more than 200 patients in active follow-up. In this survey, 76% participated, and overall we could use data from 50 centers to be included in the analysis. And these 50 centers were located in 18 countries in Europe. Most of them were located in the UK, followed by Germany, Sweden, Belgium, Switzerland, Italy, and the other countries. The survey pertained to the structure and activities of adult congenital heart disease programs, and one question was whether they had a nurse specialist on staff. And indeed, 68% indicated that they had nurse specialists in adult congenital heart disease on staff, which is not that bad. And then subsequently we approached these nurse specialists to see what is their situation, what is their level of involvement, what are their activities, what is their education, research, are they involved in research, what about collaboration with the different disciplines, and what about financing. And for the purpose of the presentation of today, I would like to go into the details of the activities. And at this figure, you can see the percentage of the nurse specialists that are performing these specific activities. And activities that are most dominant in the role of advanced practice nurses in ACHD are physical examination, followed by telephone accessibility, patient education, coordination of care, follow-up after hospitalization or outpatient visits, caregiver support, telephone consultation hours, and assessment of risk factors for coronary heart disease. Then we had a closer look at the issue of patient education. What are the things that are discussed in patient education? First of all advanced practice nurses discussed endocarditis prevention and prophylaxis, followed by cardiovascular risk factors, sport activities, information on the heart defect itself, endocarditis being the definition and etiology, cardiac risk in case of pregnancy, the hereditary nature of the disease, past treatment, and employability and vocational counseling. To a lesser extent, insurability and non-adherence with medication or lifestyle are discussed. You could wonder why so much emphasis is put on patient education in these patients. Well, part of the answer can be found here. So far, several studies have been undertaken to assess the level of knowledge in patients with congenital heart disease. And there is a consensus among all studies that there are major gaps in their level of knowledge. And just to illustrate some of these studies, in terms of the diagnosis, it's not that bad, but most patients could not draw their heart defect on a diagram. Most patients do not precisely know the reason for their regular follow-up, or they do not know what the symptoms of deterioration are. And these are important issues in terms of help-seeking behaviors. With respect to endocarditis, we do see that most patients do not know the definition of endocarditis or the symptoms that are occurring when endocarditis is present. What about the risk factors? Well, it depends on which risk factors. Some of them are well known, others are poorly understood. The level of knowledge in terms of prophylaxis is rather good, and I think this illustrates the emphasis that has been put on prophylactic measures over the past decades. In terms of preventive measures, it is, in some studies, less known by the patients. Physical activities, it's well known by our patients. On the opposite, in terms of sexuality and reproduction, here we see that only 1/4 of the patients were aware about the hereditary nature of their congenital heart disease and also about the appropriateness of an intrauterine device or being aware about the available contraceptives for them. So this means indeed that there is a need for educating our patients. But just educate them because of increasing the level of knowledge, that's obviously not enough. And we have heard about self-management. We know that patient education is a critical element, but it is not enough for self-management. And this is a model that could be used to illustrate that patient education is one step in the entire spectrum of outcomes. Indeed, we pursue patient education in order to increase the knowledge and skills, and this is needed to increase adherence to and effectiveness of the therapy and to increase self-efficacy and self-management. And at the end, the overall aim is to improve the quality of life of our patients. Again, this is only one model. More contemporary self-management models are also applicable, and also here, patient education still plays a role, but again, not the only role. So to come to the main question of the presentation of today, what do we know about advanced practice nursing and the outcomes of adult congenital heart disease? And of course, there is a lot of experience. However, the empirical data on this are very, very scarce. And I would like to illustrate this with a few very recent studies that we have conducted. Well, based on the arguments that I presented so far, we started with the role of an advanced practice nurse in adult congenital heart disease in the year 2000. And patient education is a critical element of the intervention. So we wanted to see what are the effects of the time and effort that is spent in educating the patients. And we conducted a study in which we evaluated the level of knowledge in our patients, and we compared this with the level of knowledge in patients who were recently transferred or referred to our adult congenital heart disease program. So overall, we had 353 eligible patients, of which 317 partook in the study, 226 in the education group, 91 in the comparison group. And these are the findings. The mean level of knowledge in patients from the education group was 57%. This was statistically significantly higher than the mean score in the comparison group, which was 43%. And this difference was not only statistically significant, in terms of effect size, this was a large difference. But of course, you can imagine that the group of patients that are already longer in the adult congenital heart disease program are generally older than the newly referred patients. And indeed, that's the case. And therefore, we wanted to make sure whether the level of knowledge is not only explained by the age of the patients. And this was not the situation, like you can see here at this horizontal line. This is the relationship between the level of knowledge and age, and there is no relationship between age and level of knowledge. This was not the case in the intervention group and not the case in the comparison group. So there was no interaction effect. What about other potential factors that could have played a role? So we conducted multivariable statistical analysis, and we corrected for other potentially influencing factors such as age, educational level, disease complexity, and even correcting for these variables, education versus no prior education still played an important role in the level of knowledge. So this shows us, and it was reassuring for the advanced practice nurses in our team, that indeed the time and effort that they are spending in educating patients are paying off. But of course, this is only in terms of level of knowledge. What about behavior? Well, currently we are conducting a large-scale longitudinal study to see what is the relationship between level of knowledge and health behavior, level of knowledge, and the so-called heart outcomes, morbidity, mortality. But this study is still in progress. We have a first idea based on a secondary data analysis that we did on data from a study in pregnant women with congenital heart disease. And we know that these women also need cardiac follow-up during their pregnancy. And we found a significant evolution over time, and the major breakdown was in the year 2000 when we started with the implementation of advanced practice nurses. And indeed, before the year 2000, only 44% of our pregnant women with congenital heart disease received cardiac follow-up, and this increased up to 71%. Again, this is only an observational study. We cannot draw causal conclusions in terms of causal relationships here. So far, like I said, the empirical data that is directly focusing on the link between advanced practice nursing and adult congenital heart disease outcomes are very relevant. And no surprise that this issue has been put highly on the research agenda for the future. This is an overview of research priorities, and it is based on a survey that was done among nurse specialists, nurse practitioners, advanced practice nurses from all over the world, located in North America, in Europe, and in Asia. And as you can see here, knowledge and education is #1 priority for research for the future, followed by outcomes of advanced practice nurses. So indeed, there is a room for more research in this area. It is highly needed. I'd like to come to the conclusions of this presentation. First, empirical data, empirical evidence on advanced practice nursing and adult congenital heart disease outcomes is scarce. Patient education by advanced practice nurses results in an increased level of knowledge, and the first indications are there that advanced practice nurses also influence help-seeking behaviors. But outcomes of advanced practice nurses should be understood better, and therefore they are put highly on the adult congenital heart disease research agenda. And I think researchers in the field of congenital heart disease should take these up, because we all want to avoid that our patients look like this in a couple of years. Thank you very much.
We're open for questions.
I'm listening to your presentation, really interesting. I'd just like to ask you, do you think there would be any benefit from a program, the sort of program that I was just talking about in my presentation for people with congenital heart disease to actually improve self-management skills and to overcome some of the things that you were talking about?
Definitely. Because today it's mainly based on individual and advanced practice nurses working in their setting, in their environment. The interventions are adapted to what is feasible and possible in their situation, which is good, definitely. But I think to make the next step, it is obviously that a more structured approach that is applicable in a greater region, such as Europe, such as the United States, such as North America, and so on, it would benefit patients. But again, it's still a rather young discipline. Congenital heart disease is rather new. Adult congenital heart disease is an emerging field, so definitely we need to learn from the other areas in cardiology, and we will. Thank you.
That was fascinating. I would think that one of the biggest challenges, I don't deal in adult congenital heart disease, but one of the biggest challenges is going to be the heterogeneity of this population in terms of, women versus men, and just the differences in what their structural and other issues are. That that's going to be a big challenge from the research world.
It is in a certain way. However, in most patients with congenital heart disease, there is no real genetic predisposition for transmitting their congenital heart disease to their offsprings. So in general, it's better than many would expect in a way. Some disorders are linked to syndromal disorders. Some heart lesions are linked to specific genetic mutations, but it is in a minority of the patients. So most of the patients do have a slightly higher risk of inheritance of the congenital heart disease, but it's not higher than that in most of the patients.
Philip, that was great. I always enjoy you listening to you present your work. At my institution in Chicago, Rush University Medical Center, we have a very large structural heart disease program. I see a limited number of these patients. In Chicago or in Illinois, nurse practitioners have to have a collaborative agreement with a physician. So my physician partner, sees some of these patients. Therefore, I may see some of them in follow-up. What they tell me is that they have a difficult time moving from their pediatric cardiologist to an adult cardiologist. So, and because there's such an incredible attachment to that pediatric cardiologist. So even when they're of age, they tend to, and then we have some pediatric cardiologists who do kind of hang on to their patients for that reason. So APN practice and all the activities that you reported, what are your thoughts about, the different phases as to where these patients may be?
Well, it's a pertinent issue, and there is even a bigger problem behind, and it is as soon as patients are no longer allowed to enter children's hospital, they are obliged to go to an adult care facility. And there we see in several countries that patients are lost to follow-up. We know from the literature, and this is based on studies in US, in Canada, in Germany, in UK, that the loss to follow-up or lapse of care is less permanent than the real loss to follow-up, but it ranges from 21 up to 76% is a huge problem. On the other hand, in our institution in Belgium, in Leuven, we did not have the same impression. So we also looked at the data of loss to follow-up and lapse of care, and we found only 7%. The major question now is, why is this only 7% in our institution? Has this to do with specifically hospital factors, or has this to do with country factors, healthcare system factors? Indeed, we know that US do have a lot of challenges in transferring patients from pediatric to adult care. In other healthcare systems, for instance, Canada, it is assumed to be less problematic. However, also the data on loss to follow-up are quite high in Canada as well. So easy access to healthcare, or the so-called universal healthcare, is not the only responsible factor, so to speak. Do advanced practice nurses have to play a role in this? Obviously, yes, because patients need to be informed that lifelong follow-up is needed for them. They are not seen as to be cured for the rest of their life, although they are feeling well. So advanced practice nurses can play a crucial role in this respect. And indeed, sometimes, or some organizations are calling it a lost generation, and we believe that advanced practice nurses can avoid the next lost generation.
Thank you. Take one more question from Laura.
Just a question, a comment. Well, first of all, thank you for sharing your work with us and calling our attention to the important, to the fact that more emphasis needs to be placed on children with congenital heart disease and also their transition from pediatric care to adult care. And I see Mary Canobio here, and I think she may have a comment. But my comment or my question was going to be very similar to Lynn's, and then as the discussion evolved, you know, how advanced practice nurses could really facilitate that transition and deal with some of the behavioral health issues that you pointed out. I think in PEDS we haven't done or optimized, and part of it is because the systems of care, the nurse-led multidisciplinary case-managed approach. And I think the life course approach, particularly for this population, is going to be critically important.
Absolutely. But at the same time, it's also a challenge for advanced practice nurses, because you are either attached to a pediatric cardiology program or an adult congenital heart disease program. So also in terms of involvement, it's not that easy to take up that lifelong approach with the patients. But maybe Mary and Desiree Fleck is also here in the room, can also comment on this.
Well, actually, I just want to kind of maybe summarize it. I think that is the challenge for this discipline, is that it really begins in pediatrics. It should begin in pediatrics. I mean, the work that Philip has done has demonstrated that we have not done a good job of in the adolescent and allowing that child to transfer into the adult world. And I think that's the challenge that we really are starting to look at, that we need to work more with the adolescent. And there's a whole discipline of transitional care in adolescents with congenital heart disease, and I dare say for children with all kinds of chronic illness, is that we really have to focus on the adolescents so that we won't have those deficits in the adult side. Because by the time they get to where Philip shows the deficits, they're already having more problems as a result of it, so we have to catch it early.
Thank you, Mary, and thank you, Philip, very much. Thanks to all the speakers. This was a great session.
Thank you.